Hi, well, thank you all once again for being able to join us today. My name is Aryana Sepassi. I am a pharmacist. I am an assistant professor of clinical pharmacy practice at UC Irvine School of Pharmacy. And I am very excited today to be able to present the findings of my thesis project titled The Cost Effectiveness of Letermovir Prophylaxis in a cohort of seropositive post-allogeneic hematopoietic stem cell transplant patients, which is quite a mouthful, but we're going to break it down. Very quickly, our agenda today closely mirrors that of a manuscript for obvious reasons. So we're going to be reviewing our background, research question and hypothesis, our methods, results, the limitations of this study, followed by the conclusions and the implications of our findings. So very quickly, what is allogeneic hematopoietic stem cell transplantation, or Allo-HCT for short? So taking a step back, about 1.5 million people in the United States are either living with or in remission from some sort of hematologic malignancy. Of these patients, roughly 14,000 receive this procedure each year. This figure here on the right, and I apologize, it's a little bit difficult to read, briefly goes over what the procedure is. So a healthy donor provides stem cells, and these stem cells are provided in the form of whole blood, bone marrow, or in some cases, umbilical cord blood. The blood is then processed, the stem cells are extracted and prepared for infusion into the patient. In the meantime, the patient receives high-dose chemotherapy with or without radiation. The intention for this is twofold. The first is to reduce or eliminate their cancer burden in their body, and also to prepare their immune system for the receipt of the stem cells. Once this is complete, the stem cells are infused into the patient, where they then travel to the patient's bone marrow and presumably start producing healthy red blood cells. This is a procedure that's really started gaining a lot of traction in the early 2000s, and it's being increasingly used year over year. Comparably to a time period much before this, it's really improved the overall mortality of these patients by about 41%. However, as with all procedures, also this comes with risk of complications. So one outcome we measure in these patients is known as non-relapse mortality. So in this case, this is an outcome that measures how often a patient dies due to a condition other than their original cancer. So for example, in the case of these patients, typically non-relapse mortality has been associated with other infections, other secondary cancers, pulmonary disease, or cardiovascular disease. Of these sort of associative factors, one well-studied one is known as cytomegalovirus, or CMV for short. It's an opportunistic infection, meaning that in people with healthy, robust immune systems, presumably all of us here, CMV doesn't have much of an effect because we keep it at bay. However, in these patients, who I've mentioned have very weakened immune systems, CMV constitutes a regular risk and threat. So much so that it increases the risk of NRM in these patients by about 61 to 95% compared to patients without CMV. Something important to keep in mind, this figure here on the right shows, is that CMV patients present in a wide variety of clinical scenarios or presentations. So we have anything from a patient with asymptomatic CMV, so they might not have clinical signs or symptoms, they have no organ involvement, but they do have quantifiable levels of CMV in their blood measured by PCR. And this is all the way down to patients with end organ CMV disease. So these are very critical patients who often present to the hospital with a very high risk of mortality. It just shows that this is something that we really need to mitigate in this patient population to prevent this from happening. So that really leads us to the next question: how do we manage CMV in these patients? There are two main treatment strategies that have been used historically. The first one on the left in blue is prophylaxis. So at the top, and once again, I apologize if it's a little bit difficult to read, but at the top we have our patient at transplant day 0. They've received their stem cells, and all patients, regardless of whether they have quantifiable CMV in their blood or not, receive an antiviral medication. Traditionally, we've used antivirals such as ganciclovir, valganciclovir, or valacyclovir. More recently, in 2017, the FDA approved a drug known as Letermovir for this indication. From there, the patient either may or may not experience symptomatic CMV disease. There have been some qualms about this treatment strategy, namely that we're providing antiviral medication that may be unnecessary. since we don't know if this patient may even have developed CMV in the long run or not. This leads us to the second treatment modality, which has really gained a lot of traction in recent years, known as preemptive therapy. So this is very much a cautious wait-and-see approach. So for these patients, from day 0 to day 100 post-transplant, they're carefully monitored for levels of CMV in their blood. So they visit their provider at regular intervals post-transplant. And once the patient, if they reach a certain threshold of quantifiable CMV in their blood, then they initiate preemptive therapy, which is also in the form of an antiviral medication. Traditional agents for this purpose are valganciclovir, ganciclovir, or foscarnet. Something important to note is that there's no global consensus as to what threshold should be used, so it's very individual and specific per institution. So I did mention that letermovir was one of the newer agents that's been approved for prophylactic therapy. And its phase 3 clinical trial did demonstrate efficacy compared to a placebo arm in reducing the number of patients who did experience CMV disease by week 14 post-transplant. However, this comes with a caveat. The drug cost itself of letermovir is quite expensive. It's almost $500 per tablet. Each patient has to receive roughly 100 days of therapy. So you can imagine that for a third-party payer, like an insurance company, or for a health system, this is really going to add up compared to these traditional antiviral medications, which are pretty cheap in comparison. So this led us to a research question. Is Letermovir prophylaxis really a cost-effective solution compared to preemptive therapy alone in these patients? We hypothesized that Letermovir prophylaxis will cost significantly more, with only a minimal improvement in the patient's quality of life, but may considerably improve their outcomes related to CMV. Our primary outcome to evaluate this is something known as the incremental cost-effectiveness ratio, or ICER for short. So essentially, if we take a patient and we simulate their experience on letermovir, we take the same patient, simulate their experience on preemptive therapy, what's going to be the difference in cost for those patients, divided by the difference in the expected quality of life, all things considered. But before I kind of get into the model itself that we built to assess this question, I wanted to provide a little bit of a primer on terms used in health economic modeling. The first are costs. So when it comes to costs, we think about a lot more than just drug costs. Here I wrote the cost of clinical outcomes, but this could really be anything. For example, the cost of CMV disease. A patient is hospitalized. The patient is hospitalized and is charged per day, is charged for the procedures they receive, is charged for the medications they receive, is charged for all of the labs and measurements that they receive. These are all costs that need to be factored in for these patients. The second type of input that goes into a model is known as outcome probability. So this is really related to the, clinical effectiveness or data related to the effectiveness of the medication. For example, if 70% of patients in the letermovir arm of a phase 3 trial experienced CMV viremia, then from a deterministic perspective, we assume that the probability they'll experience CMV viremia is 0.7. So we essentially take clinical data, translate that into probabilities, and insert that into the model. The final metric is known as health state utility. So it might be a new concept for some of you, but it's very easy to grasp. So it's essentially a measurement of a person's quality of life. It's extracted from data from quality of life surveys, such as the SF36, for example. And it's very simple to grasp. So it's a number that scales from 0 to 1, where 1 is perfect health and 0 is the patient's dead. So you can assume that these patients with cancer post-transplant sit in the middle. The thinking is that if a new drug comes out and reduces a person's amount of time or risk of a negative outcome, then their quality of life will improve and they'll have a better utility score. We use this utility score somewhat as a multiplier adjusted for their life expectancy. So we take letermovir, we estimate how long you live on letermovir for, and we multiply that by your expected quality of life. So this gives us something known as quality adjusted life years, or QALYs for short. So with that said, let's dive a little bit into the structure of the model. So the model was created using Microsoft Excel, and this is really a graphical representation of it. And there's two main parts to review. The first is this very large structure you can see, which is known as a decision tree. It really models the expected course of a patient post-transplant, specifically for Allo-HCT. Each of these branches represents a possible, I suppose, pathway for these patients to go under. It really depends on the probability that a patient will experience any of these branches. So very quickly, the patient starting either on Letermovir prophylaxis or just preemptive therapy alone has a chance of experiencing CMV viremia. If they experience CMV viremia, we assume that all of them will start preemptive therapy. We also made the base case or default assumption that all patients receiving preemptive therapy would receive valganciclovir. From there, the patient still has a risk of developing CMV disease. And furthermore, they also have a compounded risk of experiencing a complication, which we defined as CMV-related rehospitalization, acute graft versus host disease, or another secondary opportunistic infection. Regardless of the pathways these patients take, at the end of year 1 post-transplant, they are either alive or dead. If the patients are alive, they transition into the second part of this model, which you can visualize down here in this little box. It's known as a Markov model, so it's iterative. What does this mean? All patients who are alive enter this circle called alive. And then month after month, we repeat this cycle using long-term mortality risk estimates. So more and more patients will enter this death circle until year 10 post-transplant. And this will sort of let us estimate what would be the life expectancy for patients up to 10 years post-transplant on Letermovir versus preemptive therapy alone. I did want to visualize this another way because I understand it can be very esoteric sometimes to understand some of these terms, but you can think of it also in this way. We take the first part of the model, we plug in data related to Letermovir, we end up with the number of patients alive at the end of year 1, how much they would be expected to cost, and what their expected quality-adjusted life expectancy would be. And then we take the patients who are alive, plug them into the Markov model, and then estimate the same outcomes at year 10. We do the same process, but this time we use data related to preemptive therapy. So at the end of the day, we're comparing this box down here at the left to this box down here at the right. So very briefly, where did the data come from, right? So we did perform a systematic literature review to sort of get a sense of what data had been published with regards to Letermovir. However, there was definitely a dearth of data that was robust enough that we felt could have been used in this model faithfully. So we needed to heavily rely on the phase 3 clinical trial data that assessed Letermovir versus a placebo arm, which was essentially preemptive therapy alone. The problem with this phase 3 trial was that originally the authors had only published up to week 24 post-transplant, which is definitely not 1 year. There are 52 weeks in a year. Fortunately, the authors had published a post-hoc survival analysis looking at these data at year 1 post-transplant. So we were very fortunate to be able to use these data in our model. We also assumed that patients undergoing preemptive therapy also were at risk of experiencing neutropenia with valganciclovir. So this risk was also derived from published literature. The table on the bottom shows those utility scores I was telling you about earlier. So you can see that in the phase 3 trial, they measured these they measured the SF36, and from those utilities were extracted at different time points post-transplant. So baseline, week 14, week 24, week 48, and at year 1. So the next step was long-term mortality. So the table here, the survival at 48 weeks, only tells us mortality up to year 1. So what about years starting from year 2 through the end of year 10? So what we did was we had to look through published literature, namely because there's a lack of long-term mortality data related to Letermovir out there. So what we did was we found a paper that looked at a cohort of allogeneic HCT patients up to 5 years post-transplant. We took their Kaplan-Meier curve, digitized it, and transformed it into the survival function you can see here in blue. So you see that the blue line stops, and you can't see it, we can't read it very well, but it's month 60. What we did then was we generated distributions to try and best fit this curve in order to extrapolate past year 5. So we fit an exponential curve, a log normal curve, and a log logistic curve. We also fit this Weibull curve. And based on the AIC score, we determined that the Weibull curve was the best fit. You can see that it's not exactly a perfect fit. You see here that really initially, up to about a year and a half, there's somewhat of a deviation. However, it's important to note that up to year 1 post-transplant, we utilized other data from the phase 3 clinical trial. So we were confident that the curves that the point at which the curves matched up very closely were accurate enough to use in our long-term survival analysis. And finally, the costs. So how did we derive costs for this model? So all costs were adjusted for inflation to US 2021 using the Medical Consumer Price Index. The drug costs were based on the VA's Federal Supply Schedule pricing, as is recommended by the second panel of cost effectiveness. We utilized and incorporated the cost of an outpatient visit as well. We wanted to account for the fact that patients need to see their providers post-transplant on a regular basis. This cost was derived from CMS fee-for-service pricing. All other costs you see listed here were derived from published literature, so studies that actively measured these costs of these events in patients. So putting all of this data into the model, what did we find? So our default deterministic base case results are displayed here. So if we took one patient and if we put them through this model for a 10-year time horizon post-transplant, they would be expected to cost $74,000 roughly, compared to preemptive therapy alone, which would be expected to cost $62,000. You'll see, however, that their number of life years gained, adjusted for their quality of life, is very minimal in terms of improvement. So if we take the incremental cost, $11,000, or I guess almost $12,000, divided by the incremental QALYs gained, we get an ICER of $96,347 paid per additional QALY gained for a patient on Letermovir. Now you might be thinking, what does that mean? Right? There's no real context to really put that in perspective. So in health economics, we use a metric known as the willingness to pay threshold. So anything above this threshold, we would not consider cost effective. Anything below this threshold, we would consider cost effective. In the United States, we tend to use a willingness to pay threshold of 100,000 US dollars. So as you can see, it's very marginal, but it fits below this threshold. So from a deterministic standpoint, this would be considered a cost-effective intervention. However, there's more. We performed a series of sensitivity analyses to measure how robust this model was to the data that was fed into it. So here you can see what we call a tornado diagram. It shows the results of a series of one-way sensitivity analyses we performed. On the y-axis are all of the inputs to the model. On the x-axis, you'll see the incremental cost-effectiveness ratio. This red dotted line represents our willingness to pay threshold of $100,000. So anything to the right of that, again, not cost-effective. Anything to the left of that, considered cost-effective. So in this case, what we did is we took each of those individual inputs, we took their default value, we tested a number above that default value, ran the model, and then tested a number below that default value and ran the model again. So if the default value had, for example, a 95% confidence interval or a standard deviation reported, we simply use that plus or minus to derive the high and low estimate. In the case of some costs, for example, which we had to calculate manually, we simply use plus or minus 20% of the default value. So the boundaries of each of those horizontal bars are the ICER results for each of those analyses we performed. So you can see that when we change a few of these parameters, a good number of them cross this $100,000 willingness to pay threshold. This means that while our base case ICER determined that Letermovir is a cost-effective option, it may not be this way under every circumstance. It may mean that there's a lot of variation and variance in the data that is accounted for and shown here. This is further compounded by something called a probabilistic sensitivity analysis. So in this case, we took each input of the model, we a priori assigned a mathematical distribution to each of those inputs, and ran 1,000 Monte Carlo simulations, randomly picking numbers from each of those distributions. The results of this PSA are shown here. So sort of the initial results put another way, the y-axis is the probability that the intervention is cost-effective. The x-axis is our willingness to pay threshold. So our $100,000 is this red dotted line. And you can see that the blue curve, which is the comparator, preemptive therapy alone, sits at a probability of 55.6%. So you might be saying, that's not what your base case ICER said. You told us that it was cost effective, and here it's a lower probability of being cost effective, right? So again, this means that there's a high level of parameter uncertainty in our model. It means that the data that went into our model are not quote unquote perfect data. There's a high degree of likely variance that's unaccounted for that we need to account for in this study and in future iterations of this model, meaning that we need to look past just a phase 3 clinical trial in order to have a more confident estimate of our results. So very briefly, I'd like to review some limitations, and this is not an exhaustive list by any means, but the statistician George Box once said, all models are wrong, but some are useful. And this certainly applies in this case as well. So this model could never capture all possibilities that a patient can have post-transplant. It's impossible for us to create a model to account for all of those possibilities. So what we do is we select health states that we thought were sort of, mattered the most for these patients clinically and from a cost perspective. Also, as you well know, the clinical data were largely derived from the phase 3 clinical trial findings. And I think we all know here that this is certainly not the same as real world data. It's under quote unquote perfect conditions, right? So as our sensitivity analyses showed, deviating from those perfect conditions may very well result in letermovir not being a cost-effective option, meaning that further research is necessary. We also did not take into account other adverse events. For example, foscarnet in cases with preemptive therapy has a risk of having a patient develop acute kidney injury, which is also a very costly event for these patients. And finally, we did not take into account something known as late onset CMV. So these are patients who receive their antiviral therapy up to day 100 and then develop CMV afterward. It's thought that in cases where these patients are receiving longer and longer durations of antiviral therapy, it's taking away from their bodies to have a chance to naturally mount a defense against CMV. So once you stop the antiviral therapy, then there's a chance they'll develop CMV. So our main conclusion overall was that from a base case deterministic standpoint, letermovir was a cost-effective option compared to preemptive therapy alone in these transplant recipients. However, our model demonstrated a moderate degree of parameter uncertainty, meaning that the data that are fed into this model, again, are not quote unquote perfect. We're not certain, we're not confident of the data that went into this model, meaning that a few things, right? So what we would do in this case is we would perform something known as an EVPI analysis, or expected value of perfect information. So we use Bayesian principles and decision analysis techniques to find out, A, what parameters of this model sort of contributed the most uncertainty to it, and B, is the cost of researching those parameters to be more certain of them outweigh the cost of making the wrong decision to adopt letermovir today.